Good morning. Welcome to our 10 o'clock session. This is day 3 of CCH's 18th Annual Training Institute and Conference, Housing Equals Justice. This session is Housing Plus Services, Understanding and Meeting the Health and Support Needs of People Experiencing Homelessness. On the next slide, wanted to share, as we noted, this is our 18th year holding our annual training institute. This year we're doing this as a week-long virtual event. And our theme this year is Housing Equals Justice, which really centers on the idea of homelessness as not being a personal failure, but a failure of systems and policy. And in particular, I'm highlighting homelessness as an issue of economic justice, racial justice, as well as a need to improve criminal justice policies and practices. We have about 1,000 people registered. We have several hundred people joining each of our sessions. Really want to thank you for joining those sessions. I also want to note that our Housing Equals Justice store is online at Bonfire, so please do visit our website and you can get a link to our Bonfire store where you can purchase a t-shirt, you can purchase a mug that says Housing Equals Justice on one side and our logo on the other. You can also purchase face masks that say Housing Equals Justice, as well as things like this hoodie. So please do that, and that goes to support our Housing Equals Justice campaign. This session is sponsored by the Department of Mental Health and Addiction Services. Our whole conference is sponsored by Bank of America and Zillow, but I really want to thank the Department of Mental Health and Addiction Services, who's been a longstanding partner in our efforts to end homelessness for many years now, but really a huge partner in a number of ways in supporting efforts for homeless outreach, providing funding services in permanent supportive housing, and overall supporting our efforts to end homelessness. DHMAS has been a wonderful partner, and really at the helm of that has been Kim Karanda, who will be introducing this session. Kim Karanda is the Director of Statewide Services for the Department of Mental Health and Addiction Services, where DHMAS's homelessness programs are situated. So Kim, thank you very much for the sponsorship and also for introducing the session.
Thank you, Richard. Good morning, everyone, and I'm really so thrilled to be able to be here today with all of you. And I'd like to begin by introducing our panelists for this morning. Sarah Gallagher is currently Managing Director of the Corporation for Supportive Housing's Eastern Region. Sarah has worked extensively with state agencies to increase the use of supporting housing as a public policy solution, including project management of the Frequent User Services Engagement Program, also known as FUSE, a supportive housing pilot program aimed to break the cycle of homelessness and incarceration for frequent users of jail and shelter. Previously, Ms. Gallagher served as the first executive director of Journey Home, where she oversaw the development and implementation of the community's 10-year plan to end homelessness. Sarah was also the executive director for discharge planning at the New York City Department of Corrections, where she oversaw the discharge planning programs on Rikers Island and worked with city agencies in order to overcome barriers that people face when leaving jail. Our second panelist is Steve DiLella. Steve is the director of the Individual and Family Support Unit program at the Connecticut Department of Housing. He has been with the state working on ending homelessness for the past 12 years. During this time frame, Steve has managed a variety of state-funded homeless service programs, as well as assisting in the creation of Connecticut's coordinated entry system. In addition to Steve's role as with DOH, he serves as the co-chair for the Connecticut Balance of State Continuum of Care, which has leveraged significant resources over the past 10 years to create more permanent supportive housing units for persons with disabilities experiencing homelessness. And our presenter, Dr. Bert Plant, is the Senior Vice President for Analytics and Innovation at Beacon Health Options and has held various positions overseeing behavioral health programs and statewide systems for the state of Connecticut and private nonprofit organizations. At present, Dr. Plant is leading analyses of the homeless population and their service needs in conjunction with the Department of Social Services, the Connecticut Housing Engagement and Support Services Initiative, which is also known as CHES, and the Governor's Task Force on Housing and Supports for Vulnerable Populations. Dr. Plant is a frequent lecturer and presenter at local and national conferences. His professional and research interests include, but are not limited to, social determinants of health, health equity, treatment of opioid use disorders, and research using big data. Please join me in a warm virtual welcome of our esteemed panel. Thank you very much.
Great, well, good morning. Very pleased and honored to be here along with the fellow panelists. And I am going to be speaking about the service needs of the homeless population, and then we'll hear from Sarah and Steve with regards to their thoughts and reactions to the presentation. And then I think we'll also entertain some questions that can be submitted through the online portal. So hopefully folks can see my screen. Can I get a thumbs up for someone, from someone, just to make sure? There we go. Thank you, Sarah. So I'm going to be talking about 4 different sort of data analyses that we've done at Beacon over the years. I'm going to be pulling in data from our population profile, which includes all 850,000 Medicaid members. And we have a SUD planning grant, a substance use disorder planning grant, that's looking at the service needs and the system needs of the substance use disorder system. And I'll also be reviewing some data from the CHES initiative, which was mentioned prior, which is to provide housing and supports to Medicaid members who are homeless. And then finally, I'll also be talking about the second project that I'm currently involved with on the housing front, Governor's Task Force 500 Familiar Faces Data Integration Project. That's a mouthful, but essentially what we are attempting to do and have done is pull together data from 6 different agencies focused on individuals who are homeless and on Medicaid, and also using services within the child welfare, criminal justice, and housing service systems. So throughout this presentation, we'll be using 3 different definitions of homelessness. One is our Beacon proxy measure, and we use that for our population profile in our SUD planning grant. And really what we're doing here is we're pulling in administrative data, including Z codes, which are medical codes that reflect various social determinants of health, including homelessness or housing instability. When we get our data from the state, it includes sometimes a shelter address as the individual's address. And for us, that typically indicates that the person is homeless or has been homeless recently. Sometimes also they use a DSS office address in lieu if they don't have a permanent address, and that's another indicator. And then finally, for individuals that receive intensive care management from us, we do an acuity rating on a number of factors, including housing stability. So we put all that data together, and anybody who hits on any of those is determined to be homeless from that definition. We also have 2 other indicators from the 2 other programs where we pull in the homeless management information system data about who's used at least 1 shelter day. For CHES, it's within the last 90 days. And for the Governor's Task Force project, it's within a 15-month period between 2018 extended into 2019. So I'm first going to be talking about our population profile. And again, what this rather busy graphic shows is 2 different examples of our population profile. One that's been filtered on all adults who are housed, and then the second one that filters on those who are homeless. And I'll be just talking a little bit about some of the differences that we see between the 2 populations of Medicaid members who are either housed or homeless. And so one of the first things we looked at is behavioral health diagnoses, or the prevalence of different behavioral health disorders. again, one of the things I'll say before I jump into this further is that, I think a lot of this information is information that many of you are familiar with working with this population. But I think when you pull it all together and see the magnitude of it, it is rather impactful and really indicates the tremendous needs that this population has. So what we see is that for depression, we see that those who are homeless have 2.5 times the rate of the housed population, 2 times higher rates of anxiety disorders, 4 times higher for PTSD, 8.5 times higher for suicide and intentional self-injury, and 5 times higher for schizophrenia and other psychotic disorders. So much higher rates of mental health disorders. When we look at substance use disorders, we see a similar pattern. Nicotine-related disorders, 3.5 times higher. Opioid-related disorders, 5.6 times higher. Alcohol-related disorders, also over 5 times higher. And cocaine-related disorders, 9 times higher than the housed population. And then cannabis, about 5.6 times higher. We also look at medical comorbidities or medical diagnoses that we see. And these rates aren't as significantly higher as for SUD and mental health diagnoses, but still we see roughly 2.5 times higher for hypertension, 1.5 times higher for chronic pulmonary disease. My screen is blocked here. 1.4 times higher for asthma, and 2.7 times higher for neurological disorders. We also can see some things with regards to other indicators, such as opioid overdose. And for the homeless population, we see that the rate is 10 times higher for an opioid overdose than the non-homeless population. For opioid prescriptions, that is, who gets prescribed opioids, we see that those who are homeless are 1.6 times more likely to have an opioid prescription than non-homeless. That could be, partly due to the number of medical conditions that they have. But, it is a concern, since if they are receiving opioid prescriptions, then that puts them at greater risk for developing an issue or problem with that. And then when we look at the total spend, it's roughly on average twice as high for the homeless population as it is for the non-homeless population for Medicaid healthcare expenditures. So just a little bit from our SUD planning grant. This is data from 2018, but homeless members are much more likely to have substance use disorders than housed members. We see a rate of 60% of homeless adults that had a substance use disorder versus 16.4% of the housed adults. These homeless adults with SUD also have higher utilization of key services. They're 3 times as likely to have an inpatient withdrawal management episode, almost 1.5 times as likely to use medications for addiction treatment or be prescribed them, and nearly 1.5 times as likely to use any type of SUD service. And then just a little bit about our CHESS housing initiative. And in this particular project, so the overall CHESS project, which should be launched later this year or early into next year, it's a state program that will provide Medicaid-funded housing supports and state-funded housing vouchers to eligible participants. And as part of the contract with DSS, DHMAS, and DCF, we are the administrative services organization for behavioral health and substance use services for Medicaid. And so in that role, we are administrating or helping to administrate this program. And one of our tasks was to develop an algorithm that will identify members that are most likely to demonstrate cost savings if housed, and particularly cost savings within Medicaid. And we developed an algorithm to identify the most impactful population based on their comorbidity score and indicators of time in shelter and presence of behavioral health disorders. So we're really looking for folks who will likely have a high spend in Medicaid and have serious issues that would make them remaining homeless even more complex and difficult and potentially lead to serious medical issues. And so one of the things that we're using is something called the Charlson Comorbidity Index score. And really what it does is it looks at a person's history over the last year and what medical diagnoses and some substance abuse and mental health diagnoses they have received during that year. And based on research going back 20, 25 years, they can indicate what's the likelihood that the person will be hospitalized, what's the likelihood that they will have some extraordinary medical event that will need serious intervention. It can also indicate the risk for death in the next 10 years. And so what show on this slide is that in the top is the distribution of just the general adult population. And in the bottom is the distribution of scores of the homeless population. And so one of the things that you'll see is that if I can get my pointer to work here. So if you see here, there are relatively fewer folks in the non-homeless population that have a score of 1 or 2. A negative score is actually a positive thing. If you've lost weight after having been overweight, that could be in your favor and reduce your score into the negative range. But if you have serious diagnoses of medical conditions like COPD or hypertension, high blood pressure, those types of things, the more of those you have, the higher your score goes. And you see that for the homeless population, they have many more individuals proportionally that have 1, 2, 3, 4, or 5, a score of 5, which indicates not exactly the number of serious diagnoses, but points that sort of add up to that. Overall, housed Medicaid members have a score of 0.65, whereas the homeless Medicaid members have a rate that's almost 3 times higher, an average of 1.76. And what this really indicates is poor overall physical health, higher likelihood of a significant medical event in the near future, and higher risk of dying in the next 10 years. So, this is really just another indicator besides individual diagnoses, just of the accrual of multiple medical comorbidities. And then last but not least is the Governor's Task Force project, which I mentioned before. We're integrating data across multiple agencies at the client level. And these are the different agencies that have participated. So we have Medicaid data. We also receive from CCEH the HMIS data with regards to use of shelter days. We have data from DCF with regards to involvement with child welfare services. We have data from JBCSSD with regards to arrests, convictions, and probation, and the Department of Corrections with regards to those individuals who have been incarcerated. And then DHMAS has also provided additional information with regards to use of DHMAS services and so forth. So what we did is conducted a multi-agency data match to better understand individuals who are involved with multiple agencies over a period of time. And we were to analyze that data to inform policy and service system design. So one of the things that we looked at is we had a sample of roughly 10,000 individuals, and we wanted to see how many of these people are involved with multiple agencies. That, often agencies approach each individual based on what their particular charge is, whether it has to do with criminal justice or whether it has to do with child welfare. And yet many of these people, as the data shows, are involved with many other agencies, sometimes at the same time or sometimes sequentially. So what this rather busy Venn diagram shows is that everybody in this sample had at least 2 agency involvements. because everybody had to be at least 1 day in shelter and they were on Medicaid. So we started with that pool of individuals who were homeless and on Medicaid, and then we matched. And so someone could have anywhere from 2 to 6 different agency involvements. Somebody who had 6 was obviously had received services or been involved with all 6 of the agencies listed here. And this is just a high overview. There's a lot more data behind all of this, but a high overview of what we found, which is that, so looking at the overall sample of 10,420, roughly, again, 100% of the sample was involved with HMIS and was involved with Medicaid, but almost 60% had some historical involvement with DCF, close to half or 46% for both DHMAS and DOC, and 50% for JBCSSD. And so very significant, interagency involvement within this population. This bar chart to the right here shows the overall number of involvements that each individual might have. So about 12% of the population was involved with just 2 agencies. 28.6% were involved with 3, and then so on for involved with 4 agencies, 5 agencies, and 6 agencies. If you add these 2 numbers together, you see that roughly 40% were involved with either 5 or 6 agencies. So a lot of interagency involvement for the overall sample. When we looked at individuals, meaning those who were not connected with a family in the HMIS data, we saw 52% involved with DCF, so a little bit lower than what we saw with the overall sample, and then somewhat higher rates for DHMAS, DOC, and JBCSSD, all in this low 60 to mid 60 percentage. And then again, we see that there's even higher rates of multiple agency involvements, with really over 50% of the sample having either 5 or 6, when you look at just individuals who aren't connected with a family. Looking at the same data, we looked at families also, and that is a head of household and their children and other relatives who might have been sheltered together. An interesting pattern here is that, and I don't think this is too surprising, almost 75% of them had some involvement with DCF at some point, almost 3/4 of them. We see less overall interagency involvement with families, most people falling in this range of 3 involvements, and most often that's involvement with DCF, as well as the shelter system and Medicaid. When we looked at the head of households, we also see that 80% of families that were homeless and on Medicaid had a history of some type of involvement with DCF, and over 86% had 3 or more agency involvements. So we also looked at who was high need within each agency. We established criteria for each agency, working with them, and then we look to see how that applied to each individual in the sample. And in this case, you could be anywhere from have high need with none of the agencies or 6 of them. So a range from 0 to 6. And so the summary of that, again, a lot more data behind this. We looked at demographics, gender, race, ethnicity, et cetera. But what I can show you here in the time that we have is that a much lower percentage of the population, kind of by design, was considered high need. And so out of the 2,466 of the 7,300 individuals were determined to be high need with 1 or more agency, and the percentages are listed here. What you see is that most people were not considered high need, or 66% roughly were not high need with a particular agency. And I guess what I would say here is, when I say high need, I mean highest need. So they might have high needs, but they weren't in the group that was highest need, which is what was defined over here. And again, we see that 21% roughly had high need with one, and a smaller group of individuals had 5, and none were high need with all 6 entities. When we looked at the 3,091 total family members, there were 989 of those family members who met the criteria for high need, and 539 out of 1,000 families, so roughly a little over half of families. And so basically the small percentage, 519 out of 3,091 of this sample is high need with at least one agency, and 68% of all family members did not have high need status in any agency, slightly higher than what we see for individuals. So there are some distinct differences. So let me just kind of summarize here, and then we'll get into our discussion. So what we see in the homeless population are significantly higher rates of depression, anxiety, PTSD, and psychotic disorders. I call out the rate of suicide and self-injury being 8 times higher than the housed Medicaid population, and that's a great concern. We see significantly higher rates of substance use disorder in general, particularly opioid, alcohol, cocaine, and cannabis. Significantly higher rates of medical disorders, hypertension, COPD, asthma, and neurological disorders, and higher medical comorbidity and risk of death, which was based on that Charlson indicator that we did, and a 10 times higher rate of opioid overdose. So, you know, some of the things that really stood out were the rates of self-harm and self-injury and the rate of opioid overdose. They had double the average adult rate of total Medicaid spending, higher risk of death and serious medical risk due to comorbid medical conditions. Individual homeless Medicaid members have typically been served by 4.5 of 6 key service providing agencies. That's what we found was the average, was 4.5. 80% of families that were homeless and on Medicaid had a history of some type of involvement with DCF, and 32% of the individuals were considered to be high need with 1 or more agencies. So that's essentially the summary. And then we pose these questions, but you know, I'll turn it to the panelists to comment about anything that they heard or any policy implications. But I guess the first broadest question is, what does the data suggest regarding the approach to service delivery for the homeless population? So we can start there.
Great. Well, thank you, Dr. Plant. That was really powerful data. I really appreciate it. I think seeing the data and bringing it together from the multiple sources and perspectives is really just phenomenal. And I thank you for that. It's just what we should be doing and looking at it. So before I get started, I want to remind folks that there is the Q&A box. So be sure to put your own questions in there, and either Dr. Plant or myself or Steve can try to address them as well. But I will start with some reflections on that data on the approach to service delivery for the homeless population, because I think, you know, in my career, you know, Kim talked a little bit about some of the work we've done around targeted initiatives for high need populations, right? Fuse and CHEST. And I think what really stood out to me around this data was, you know, this is more than a targeted intervention approach or an approach for one population, one segment of the population, that it really is a population health issue across the whole homeless people who experience homelessness, and that we really need to start looking at the integration of health and homelessness more across the whole population and less around different subsets of the population. So I think, thank you for enlightening that for me and really giving some data that shows that. And so when we think about your question around like service delivery, I think, you know, something you highlighted in the data thought was really powerful, especially got to end. You really had this build, and I'm going to take some liberties. I know these are different subsets and different ways of looking at the data, but to tell a story across the data, because I felt like it really built from looking at the needs of the population of people experiencing homeless around, around depression, around high rates of suicide, around substance use disorders that are really prevalent across the population. And then as we got to really the story around service utilization, really seeing that people experience homelessness are not in vacuums. They're really touching a multiple of our mainstream service systems that are designed to serve them, right? Or should be designed to serve people with the needs that they're presenting with. Yet, when you look at that last slide, very few, and Dr. Plant, correct me if I'm taking too far liberties, but very few are rising to the level of high need in any one system. So therefore, I would hypothesize that they're not getting the services of the high need services that are offered, and interventions that are offered through those service systems. They might not be getting the intensive care management or the high need service for which they'd be eligible. So I think that looking at the data this way is great. And now how do we translate to our service delivery systems, where we're looking at people more holistically and through the multiple systems with they touch. And I think you mentioned CHESS a little bit, and that is something that we're trying to do through CHESS, where really look at how people are using homeless system and their healthcare needs, and create a service delivery system that has behavioral health services, is connecting to primary care, and is addressing housing stability at the forefront. But how do we start to do that for the broader population of people experiencing homelessness is something that was really stood out for me in this. I think the second thing around service delivery, when you looked at the Charleston Index, is really that relationship between housing stability, people who have housing and people who don't within the same population, and really that is a fundamental foundational part of the service delivery system for people to be successful and to not have 10 times higher rate of dying in the next 10 years, or really creating healthy options and opportunities for people to thrive is really foundational. I think for the service delivery system, I'd be really interested. I think that there's some emerging models that are addressing some of these issues outside in the homeless system and outside of the homeless sphere. I mean, one of the models that we're looking at are the integration of community health workers into the homeless and healthcare system, and creating that bridge between the two systems. So can we look at, how do we create from the homelessness side more knowledge and experience and able to navigate and help people navigate the health system and the behavioral health system, because clearly there has to be that expertise and that integration. And so can we do that through peer supports or community health worker models that have really proven to provide great care coordination in other spheres, and in places like Houston and with Healthcare for the Homeless programs have really started to lift up better outcomes in creating that bridge. So from a service delivery perspective, I'd be really interested to think about how do we create opportunities to create that glue, lift up the knowledge and expertise of the homeless system to be able to navigate that world. But I think just as importantly, this doesn't, I think your data suggests to me, it just doesn't fall on the homelessness delivery side. It really, the real gap is in the other system, the healthcare system, the criminal justice system, the DCF systems that are seeing people early on, if you look at the DCF system, probably when they're young. And what knowledge can our homelessness providers provide in recognizing the holistic approach to working with people, and thinking about the symptoms people present with, and really diagnosing them accurately and timely is something that I think from a service delivery side on the front end is something that we could think about. I reflect back to my time at the Department of Correction in New York City, where we were doing discharge planning and connecting people with mental health services for when they were in the community. And what I saw there was a real difference between, you know, people would present to Department of Correction and we would assess them of having a mental health disorder or having depression or having something that needed an intervention in the community. And back in New York, when they would be assessed by the behavioral health field, those symptoms were really seen as a criminogenic symptom. They weren't seen as a behavioral health or depression or something that needed a behavioral health intervention, but really something related to their criminogenic background. And I think that that is something that still is pervasive in our symptoms, where we only look at people from our vantage point and sort of don't necessarily diagnose or provide the interventions for what people need, because we're taking the homelessness or accounting some of the symptoms to other parts of their life that our system isn't able to deal with, and then we don't follow up to make sure that they're receiving that intervention or that service outside of our own system. So that's really integrated service model is something that we really need to get to as we move forward. Steve, I want to see what your reflections are, so maybe we could talk a little bit, but those are some of my initial thoughts around the service delivery piece of it.
All right, I also agree that I think the data that Bert and Beacon you've been able to do is quite incredible. I think it's almost vindicating in a way. We certainly heard from our providers on the ground for years and years and years, the overlap between different systems, but you know, even though we've heard it, we've never really been able to put you know, numbers or a finger on the pulse to really determine, you know, how far some of these connections go back in time, whether it's the DCF system or, you know, how corrections and mental health and substance use play a role. So I think it's really great just to sort of have that data to back up, you know, what we've been told forever on how to address this. And I think what's really important too is, you know, how do we look to work together in partnerships. Certainly we have created a lot of relationships here between state agency partners. We do have our interagency partnership that really is tasked with providing that level of supportive housing, is tasked with, you know, how we work together as state agencies to identify these folks that kind of share our systems. And I think this will also give us the ability to dig a little bit deeper and actually identify them, so we can be a little bit more proactive and really see those individuals and households that are within the 3 to 4 to 5 different systems, and how do we create interventions that are better suited for their needs. And I often think of, when I think of homelessness in terms of systems, it really does seem like, well, what happens with individuals who end up homeless? We know that there certainly is an affordability issue here. We know that, you know, one of the main reasons for homelessness is, you know, people can't afford the rent. However, there are these other pieces to it, and, you know, it really relates to service needs. It really relates to, you know, the issues that any individual is experiencing, and those are the barriers that may prevent them from resolving their housing instability at a level before it reaches homelessness. So we need to think together on best practices within our state agency partners and say, okay, well, in the DCF or the DHMAS world, this is interventions that work well with a similar type population. So how do we collaborate and coordinate on better ways to provide, you know, housing case management to be able to relate to those programs. I also think it leads to the point of how do we work as state agencies as well to kind of break down some of the silos that we have and some of the barriers that we also have. You know, one state agency may have, you know, a specific goal that meets their agency needs, whereas another state agency may have exactly opposite goals. So how do we be able, if we can't navigate our own systems as state agencies, how can we expect the folks that we serve to be able to do that? So in order to be successful, how can we kind of think about you know, what each of our agencies are requiring, and how does that work so that we aren't putting folks at a disadvantage that would not allow them to be successful, especially in the area of housing. Because I think we all would agree that in order to to have success in treatment, in order to have success with recidivism, in order to have success with some of our other systems, one of the main points is to have stable housing. If we don't have stable housing, if you don't have a place to call home, if you don't have that solid base, it's difficult to focus on a lot of these other issues that individuals may have. So I think it really is, the data really shows that this is a call for us to work as collaboratively as possible to really identify how best we can work together, how best we can put together best practices and really provide that level of service to these folks so they don't, in a way, slip through the cracks and end up in our homeless service system. If we can do a better job of identifying in the beginning, and maybe this data can kind of help us lead that, and maybe do some, analysis and tracking of how folks ended up from one agency to another to homeless. If we can start identifying some of those risk factors, maybe we can actually do a better job of preventing homelessness upstream by, maybe providing a quicker response to housing insecurity and combining that with our state agency resources to really provide stability so that folks can kind of get back, on their feet and just move on with their lives without even connecting with some of these other state systems. So I think it provides certainly a wealth of information, and even though it provides the great data, in my opinion, it opens up a whole host of different questions on how we can collaborate and work together to be able to resolve these issues.
Great. So Steve, I think we're next asked to talk about what are some of the policy implications of the data. Do you want to go first, or do you want me to?
Sure. I think in a way I was kind of leading into that policy discussion by looking at, how you see the interaction between different agencies and how things, how a variety or how many folks who are experiencing homelessness have different interactions with different state agencies. So in terms of policy, I think one of the things that I've seen a great deal of focus shift in the past 10, 15 years is, these agencies across the state are now realizing that housing is one of the most important social determinants that they can have for providing success in terms of their outcomes per their individual programs and their individual agencies. So I think that message needs to keep being progressed farther and farther. It's not necessarily always just about more treatment options. It's not necessarily about more, medical or other types of care. I think a lot of it has to do with just looking at where the individual is living and ensuring that they have a safe and stable place. And from there, we can kind of build on that success and then be able to provide those other supportive services to maintain their stability. And I think we can probably be much more effective and efficient. And I think it also could be much more cost effective. So we're not cycling between different programs, different models of service, which can often be confusing to the individual. So if we can kind of agree on what the best path is for some of these folks that have multiple agency interventions, I think that can be certainly a place to start, and it's certainly a place to be able to provide a better level of care that will have positive impacts on all of areas of the individual's lives and on all of our state agencies as well.
Great. Yep. I think that's great. I wholeheartedly agree. I think, I'm actually thinking like the theme of our summit or this week is housing is justice, and I think this is telling us, back to our theme, that housing is also healthcare, right? Like they cannot have one without the other. And like in policy world, how do we, you in a state agency, that the silos in the pocket, the moving money from one pocket to the next in state government, in federal government, is often really hard. And how do we get to do that and really on a fiscal and policy realm integrate these systems?
I totally agree with the whole silo issue. We're always siloed, and I think that's one thing that I've certainly always tried to address is how do we break down some of those silos, because it really doesn't make any sense. And how do we also look and determine, that housing really is an important piece of success. And so it isn't necessarily, we need to refer to this agency for that. We need to refer to this agency for this. It really just needs to be a more holistic approach that really isn't thinking about the silos of what we're required to do by our funding, but it's how do we think about the service needs of the individual and how can we best provide that in a more holistic fashion.
I think, Dr. Plant, one of the things I'd love to see too, I think this data really highlighted the health disparities among people who experience homelessness, but I know, especially in the CHES work, we've talked about the racial disparities as well, and they go hand in hand, and I think that would have even more significant policy and system implications as we go forward, as we dive into that piece of it. I'd love to see that as a next cut.
Yeah, so we have done a bit of that analysis, and particularly for the CHES program, when we developed the algorithm that was to select individuals who would be eligible for CHES, we had become aware, because it's something that the healthcare system has recently become aware of, like in the last year, that many of the algorithms that are built to select who should get specialized services end up being biased because of existing biases in the way healthcare is provided. And so one of the things from a policy perspective that I'm pushing at Beacon, and not just in Connecticut, but more broadly, is that we have to be really sensitive to that. And we have to make sure that if we're using algorithms or we're developing them, that we test to make sure that they're not going to be biased against any particular group. And in the first iteration of the algorithm that we developed, we tested it and we found, lo and behold, it was, because it depended on using a history of prior utilization of services. And we know that typically minority populations utilize less service. So if that's your indicator of who needs more service, you're going to disadvantage people who don't often use services or don't as often. So I do think that that's a huge issue when you look at the comparison of the HMIS data versus the Medicaid data in general. There's more minorities within the HMIS data than in Medicaid in general. I also think one of the things I will say that's a really good thing about the Homeless Management Information System is that they have very complete data with regards to race and ethnicity, and not all our systems can say the same. And when you're missing data, then it makes it a lot harder to assess whether you're being biased or not.
Great, that's great. And I think one thing this is highlighted for me on that policy side around, you mentioned around service utilization and how sometimes it's lower for different populations and different race or ethnicities, is a lot of our policy conversations have been built off of this return on investment model, right? We're going to save money by doing the right thing and providing housing and services. And I think one of the things I've learned and would encourage is that we don't solely make decisions or allocate resources on this return on investment model because of what you said. Like, a lot of the times we need to invest in housing and in services for people to ensure health, right? And ensure people can thrive and people are getting the right medications or the right services to sort of break the cycles and increase the chances of living in the next 10 years rather than increasing the chance of dying. And I think that is something from a policy framework we can think about is, we know we need more housing. We know we don't have enough community-based substance use treatment services or intensive mental health services in the community. So how do we start to make those investments and move away from this return on investment model for these sort of services that should be a human right for people, rather than, only having enough CHES vouchers because this is how we save money, when we know that the population that needs them is greater than what we can provide on a return on investment model, is something that I think we need to dive in with your data in this and to start to make decisions a little bit differently when it comes to policy. So what the next question was around I don't know, Steve, do you want to talk about, what are some of the barriers that to effectively serve multiple agency involved homeless individuals, or really talk more into what are the, what do service providers need to learn or learn more about and able to serve homeless individuals well, given what we've learned today?
Yeah, I think that's a really interesting question. And I think some of our providers are probably even more well-schooled and well-versed at this because they do this on a day-to-day basis. But I do think it goes back to really having those conversations at a bigger level and really trying to identify really truly what are the barriers that what each system is requiring that may negatively impact the outcomes on a different system. So, like when particular, if you're talking about the DOH system and, how we are very focused on housing first and low barrier approach and kind of meeting people where they're at. Often cases, if you're using that may be a negative outcome for some of our other systems, which can lead to, either reincarceration or, including in a higher level of restrictive living in other programs. So I think how do we kind of get to that notion of how we can work together to figure out ways to be able to assist the folks that we serve. And I know that when I talk with our folks at probation, I know that they are so interested in being collaborative as possible because, it's not in their best interest either to have high recidivism rates. That isn't necessarily what they're looking for too. So how can we really get to some of this level of a mutual understanding of the type of service that we can provide that is beneficial to both both agencies as well as for the person. And it does go back to that whole silo issue and how we can kind of break some of these things down and think more holistically about the individual and what their true needs are. And I think that's where we need to start as a statewide partners is what can we all agree on are our shared goals. And I think if we come up with ideas of what our basic shared goals are, I think from there we can kind of start building on types of services that work with them. And I also do think it makes a difference on how we talk to the folks that we serve. I think we all need to be talking to them in the same manner and really have the same type of ideology on the way the services should be delivered, because I think that will really go a long way in making the folks that we serve comfortable, making them understand that we are all moving in the same direction so that hopefully they don't feel that push and pull between different requirements that we may have.
Great. I'm going to move to a question in the chat or the Q&A. And someone's asking, and Steve and Bert, I'm not sure who would be best, but how can an individual receive assistance from CHAS program? Is it referral or can they self-refer? Or how would you do so if you wanted to self-refer?
So I think some of that is being still figured out as we speak. Yeah. And I think the short answer is that the primary mechanism is going to be looking at the population that's been sheltered and that has been a Medicaid eligible person, and looking to see among that group who meets the criteria of the algorithm. But I'm also aware that there will be other methods because not every homeless person uses shelters. We expect to have people who maybe have been incarcerated for a period of time and are coming out, and we won't have all the data that will help us to do the algorithm. So there will be some type of other self or other referral pathway in as well as, but they'll also need to meet many of the same criteria. It's just we're going to need to find different ways of getting the information in order to decide. So maybe that's not as clear an answer as somebody would like with a phone number where to call, right. But some of that's still being discussed and decided upon by DSS and the group that is advising them with regard to the program.
Great, thanks. And then the second question we have is a great question. What if more of the services we have is not the whole answer? What if we need more flexible supports that start with the person? Seek support, support greater agency for people experiencing homelessness, with greater emphasis on building relationships inside our systems and in the community. So yeah, sort of this agency and network and system. You guys have thoughts on that?
Yeah, I think that is very similar to what I've been kind of discussing so far today. I do think we need to think greater. I really do think we need to think at the individual level and try to build the level of support from the individual, from that person-centered approach, to identify what their needs are, more so than what we say we need to do, because we have some requirements that need to be met. So I know it's often difficult when we do have guidelines, especially from the federal government, that says we have to do things a certain way. But I think we need to think creatively to be as flexible as possible to meet people where they're at, because I think if we do that, our success will be much greater than trying to put restrictions on individuals.
Absolutely. That's great. Yep. And I think as, service providers and peers, what we can do is really inform ourselves and learn about these systems, right? Learn about CHES, learn about the WISE waiver and behavioral health homes and intensive care management programs, and learn about some of these programs that exist in other systems so that we can help navigate when we see that. And when someone says, hey, I think I want to apply for a CHES program, we can learn how to do that. Or if I think I want to be a part of, I can benefit from XYZ services. And so really starting to know those other, navigate those services could be really, really helpful.
I do think there are, tremendous challenges to all of the individuals, I'm sure many of whom are attending this, who are working directly with the homeless population, because there are so many different complex systems. And we had an experience where we had a program where we were looking at individuals with high need from a behavioral health perspective. We had a 4-year program. And what we learned, which it opened our eyes because we were not as aware, many of them were homeless. And many of them, in addition to having significant behavioral health issues, had a lot of serious medical problems. And our staff really wasn't prepared with how to deal with that. Sometimes they had to go into the hospital, and we had a certain protocol, and we had to adjust that because people were too medically compromised for us to meet with them and try to get their consent to participate in the program. And our staff needed a lot of support with regards to understanding medical diagnoses and so forth. So I think there's a tremendous amount of information to master so that you can be most effective advocating for those that you're working with. And we could probably do a better job, together, to put together some type of training curriculum or other thing that would help people to better do that.
I love that. I love that, Bert. I think that's right. And I think we saw through SIF that need where we train people to a handful of supportive housing providers and patient navigation, but seeing your data, that is I think that's the future, is that supportive housing and homeless providers are going to need to know more about the healthcare system. And then, how to care for yourself when you're dealing with folks. We saw in the SIF program, the most common way people left for housing was they passed away because they were really sick, but they died with dignity. They died in a home, and but how do you support your staff and yourself as you're really supporting others through really hard life challenges? And I love the idea of coming together to create curriculum and training and to help support the direct frontline staff to support people that they're working with day to day. I think we can do more of that. And around, with opioid use and with, Narcan and all how do we prevent overdose prevention? How do we really enable people to talk really around harm reduction and the other issues that they need to address day to day? Any other questions in the chat? You have a time to type one more in before we head over to our next session. But I want to thank Bert and Steve and Kim. This was a great conversation to have with you guys.
Yeah, I just want to say thank you very much for including me in this. Again, I would not consider myself a housing specialist, although I'm certainly learning a lot in this past year with my involvement with these two projects. But I do think it is valuable to be able to use this data, and not just use it in sort of an academic process, but if we can get to the point where we can really share data so that in real time you can find out when someone you're working with has gotten hospitalized and where they are and or they've hit the ED, and what kinds of services they might most be in need of, I think that would be tremendously helpful.
That would be great.
Great. Well, I just wanted to also extend my thanks to all of you, Dr. Plant and Steve and Sarah, for your remarks. The presentation you gave, Bert, is stuff that we've long known about our homeless population, but to see it put together like that and to have hard administrative data that backs it up, just I think is a wake-up call to me. So I really appreciate this conversation and the idea that we need to do better and more and to break down silos. And again, I want to extend our thanks to Tim and to DHMAS for sponsoring this workshop, as well as our other workshop on Friday. In closing, if we could just pull up the a slide here. We have more to come, believe it or not, in this session, including a wonderful keynote at lunchtime from Bobby Watts in keeping with this theme around housing as healthcare. Bobby Watts is the president and CEO of the National Healthcare for the Homeless Council. He'll be talking about the trifecta of COVID-19, systemic racism, and homelessness. But coming up next is a training on critical time intervention and rapid rehousing. CTI actually is an intervention that's intended to help people develop a system of support around them as they're moving into housing. So, may have at least one of the answers for this question about how do we address the health and service needs of the population. And then this afternoon, a lot more, to follow up on Steve's point about breaking down silos, we have trainings for McKinney Vento liaisons within schools to identify students experiencing homelessness, and then a session on the consequences of children experiencing homelessness. And then please do join us for our happy hour at 4. But again, thank you to our panelists for this excellent workshop on housing plus services, and please join us at the next session. Take care.